Hi everyone, thank you so much for the invitation to present today. My name is Nelly Faghani and it's always an honor to present on anything pelvic health related, but especially on a topic that is so unrecognized and misunderstood and unfortunately takes often decades to diagnose and treat. And I'm doing this talk in April, which is I think very time appropriate, seeing that May is EDS and HSD Awareness Month, and I'm honored to show my support on presenting on pelvic health physiotherapy in this area. So I wanted to start off with some disclosures. I guess first and foremost, I'm just a physiotherapist. I'm not an expert in this area. I've certainly had the privilege of working with many patients and understand that each person presents very differently. The brave stories that I've heard really has given me a glimpse on how much the quality of life is affected in this population. So hopefully today's talk validates some of the pelvic floor dysfunction symptoms that you may be experiencing and provide some conservative possibilities that you could explore. The next disclosure is that I am owner of Pelvic Health Solutions. This is a Canadian postgraduate educational company, and what we do is train healthcare practitioners, particularly physiotherapists, in treating pelvic dysfunction. The next disclosure I have is that I am part owner of 7 physiotherapy clinics in the Greater Toronto Area, and 4 of the clinics that I work out of are listed here. So my objectives for today is just to go over what pelvic floor function is and go a little over the anatomy, talk about common pelvic floor dysfunctions and what those symptoms might look like, give you an idea of what pelvic health or pelvic floor physiotherapists do, what would happen if you made an appointment, what that assessment would be like, and what some of the treatments might look like. Because I think typically people think that pelvic floor muscle training, strengthening, is really what we do for everyone that has pelvic floor dysfunction, and I want to debunk that thought. And also, if you're interested in finding a pelvic health physiotherapist, I want to give you some options. So what is pelvic floor or pelvic health physiotherapy? Well, it's based on the evidence. So it's evidence-based treatment for various types of pelvic floor dysfunction. So this could be incontinence, prolapse, overactive bladder, which is going to the bathroom more than 8 times during the day and even getting up at night to go to the bathroom. You may or may not have urinary leakage with this. We see people pre and post surgically, during pregnancy and after, and various pelvic pain conditions and even bowel dysfunction. So physiotherapists need to take special postgraduate courses in order to learn the assessment and treatment techniques in this area. And they learn the skills to do a digital, vaginal, and or rectal evaluation of the pelvic floor. And when I go through the anatomy, you'll see why that may involve an internal exam, but that would be discussed with you. I wanted to talk about this one study by Palmer et al. In 2015, which was a survey amongst physiotherapists in the UK that found that only 32% of respondents actually received formal training in EDS HT management. Unfortunately, many physiotherapists and other healthcare professionals are not familiar with the diagnostic criteria, prevalence, common clinical presentation and management. Hopefully, opportunities like this will help change that. So what is our treatment approach? I already mentioned that our treatments are all based on the evidence. So it's evidence-based treatment. We also take a very biopsychosocial approach. So what that means is we not only look at the bio, so the tissue piece, but the evidence also shows us that there are psychosocial contributors that can make symptoms worse. We have a very trauma-informed practice, which means that there's various forms of trauma that clients may have experienced that may have been sexual trauma, childhood trauma, even medical trauma. And so trauma-informed practice is a framework based on the objective of fostering feelings of safety and control for the patient who has experienced any type of trauma. So we're very gentle, consent is critical, everything is explained, and we only move forward if you're comfortable. we really listen. You know, we need to build a strong therapeutic relationship, and that's what gets the best outcomes. We're very patient-centered, which means that goals that are important to you are what we're going to be working towards. And really, an individualized treatment program is made for you, and that program may include some education, possibly some manual therapy, or some exercise. Now, we all know there's lots of benefits of exercise, including protecting your heart, your bones, and your brain. It can help improve sleep quality. It can help decrease pain, help with joint stability, even help with your mood and decreasing anxiety. But in this population, even though we want to promote safety and movement, we have to be very careful and pace appropriately and have special consideration of many of the symptoms that you might be experiencing. And that includes pain, fatigue, dizziness, or even nausea. So sometimes when it comes to exercise, less could be more. But again, it's very individualized and patient-centered. Our treatment approach also includes collaboration, so communicating with other members of your team and sometimes making appropriate referrals when indicated. So let's talk about pelvic floor muscle function, because these muscles kind of just do their job without us giving much thought about it, right? Unless that there is a problem. A lot of people don't even know where the pelvic floor muscles are, so I just wanted to point them out to you in this picture that's just from the side. So this is the pubic bone at the front. Right behind that we have the bladder, then we have the uterus, and this is the vagina, this is the bowels, and this is the spine, and at the end it's the tailbone. And as you can see in red, the pelvic floor muscles start from the front and they go all the way to the back to the tailbone. So that brings me to the first function of the pelvic floor that I'm discussing today, which is sphincteric. So this is the same view, just depicted differently. So the muscles are here, front to back, and they go around the openings of the urethra, which is where the urine comes out. They also go around the anus. So they help control the opening of the urethra, the vagina, because they go around the vagina as well, and the rectum. And if they're working properly, they help you maintain urinary and fecal continence. So I want to talk specifically about urinary incontinence right now. This is very common, and people don't talk about it, but it has a huge impact on quality of life. There's a lot of social consequences, including decreased self-esteem. It can impair your emotional status. It can lead to depression and isolation. It could lead to impeding social activity and physical activity. So it's very, very important that we are here talking about it today. So stress urinary incontinence is the loss of urine secondary to an increase in intra-abdominal pressure. So if you cough or sneeze or even get out of a chair, anything that increases that intra-abdominal pressure, if the urethra is moving around too much and not being supported behind that pubic bone, you could have loss of urine. And so stress incontinence is a loss of urine secondary to an increase in intra-abdominal pressure. Then we have urge urinary incontinence. So this is the loss of urine associated with urgency. So it's that inability to delay. So it's losing control on the way to the bathroom. Then we have mixed urinary incontinence, which is a combination of stress and urge. So this was an excellent review that was done by Patel et al. In 2021, and it showed the prevalence of urinary incontinence in women with EDS to be at around 70 to 84%. Now in the general population, that's at around 30%. So you could see it's significantly higher. And that is why it's so important that we talk about it. And patients with EDS were likely to present with multiple symptoms. So not just urinary incontinence, but vaginal prolapse, which we're going to talk about, overactive bladder, voiding dysfunction, so maybe inability to empty their bladder, which increases the risk of urinary tract infections, pelvic floor pain or spasm, and even fecal incontinence. And in this population, the prevalence was noted to be 14%, which is really high because in the general population, that's only at around 2%. So the impact on the quality of life is massive. The good news is that bladder training has a cure or improvement rate of 67% after 3 to 6 months, aiming to strengthen the pelvic floor muscles. And what that does is it hypertrophies them. Any muscle that you exercise, it can get thicker and stiffer, and it helps support the urethra against that pubic bone to decrease urinary leakage. It can help suppress urinary urgency as well. So pelvic floor physiotherapy can have a significant impact on treating symptoms of stress incontinence and overactive bladder. But special consideration in this population has to be taken with devices such as vaginal cones, and these are weights that are put inside the vagina to help you identify where the muscles are, or with the use of things called pessaries, which are silicone devices that are put inside the vagina to help support the urethra. And this is because they can provide a mechanical obstruction, which can reduce the ability for you to empty your bladder and increase your risk of urinary tract infection. So it's very important to talk to your primary care practitioner or referring doctor regarding these things, and special consideration has to be taken. So this was a scoping review done by Jillian et al. In 2020, where they looked at 105 studies just to see what the literature said with respect to urogenital and pelvic complications in this population. And what was very interesting is that urinary complications were the most frequently reported, with over 40% of the studies reporting one or more related problems. So that included various types of incontinence. We talked about stress and urge, but even leakage during intercourse or at night, recurrent bladder infections, bladder pain, dysuria, which is pain with urination, retention, urinary retention, and voiding dysfunction. And there were a lot of other urinary complications that were also noted, but I didn't list them because they're not within the scope of physiotherapy. So the next function of the pelvic floor muscles that I want to talk about is support. So these muscles, like I showed earlier slides, start from the front and they go all the way to the back, but they also go side to side. So they're a basket of muscles that help support the organs against gravity or intra-abdominal pressure. Now, this picture is a really good one that's often used in the literature called boat in the dock to show the role of pelvic floor function in supporting organs. So the boat in this picture is equivalent to the pelvic organ. The water is equivalent to the pelvic floor muscles, and the guy wires holding the boat up are equivalent to the ligaments and fascia. So as you can see on the picture on the left, the boat is being supported high in the dock. Now, if the pelvic floor muscles are thinner or weaker, they've atrophied, you can see that picture on the right, the water level is going to be lower. So the boat is sitting lower in the dock and the ligaments or these guy wires have been stretched out. So the idea of pelvic floor muscle training to thicken the muscle is really bringing the water level up so that we're able to support the boat higher in the dock. Now, what's important to say is that once the ligaments have been stretched or the fascia has been stretched, that cannot be changed. The only thing we can really impact is the pelvic floor muscles. So that's what pelvic organ prolapse is. It's really the boat sitting lower in the dock. And what clients are experiencing is pelvic pressure or feeling an annoying protrusion at or near their vaginal opening. So it's the descent of pelvic organs. It is not a disease, it's a functional problem. These symptoms of pelvic pressure are usually aggravated in gravity-dependent position like standing and are often relieved by lying down. The name and type of the prolapse is based on the organ that is descending, so I wanted to go over that with you a little bit. The top left corner here is the quote-unquote normal anatomy, where, let's just go over it again. This is the bladder, this is the uterus, this is the vagina, and this is the rectum. So if the front wall of the vagina is compromised, then the bladder sits into the vagina. That's called a cystocele. If the back wall of the vagina is compromised, then the rectum comes into the vagina, and that's called erectocele. Now the uterus could descend down, and you can see that in this picture, and that's called a uterine prolapse. And if the uterus has been removed, that's called a hysterectomy. Then at the top we have a vault, and that vault could also prolapse down. In this review, 21 out of the 23 studies supported a correlation that there is an association between hypermobility and pelvic organ prolapse, and there are higher rates or greater severity of pelvic organ prolapse in this population. So women with EDS or HSD are thought to be at a higher risk of prolapse due to the reliance on collagenous tissue for support of these structures. And unfortunately, the risk increases for prolapse and incontinence after childbirth. And so the research says that conservative management should be considered for those women who are planning to conceive or immediately postpartum. Now, the research is great in this area, and it shows that pelvic floor muscle training is effective and cost-effective in reducing prolapse symptoms and should be considered first line. So what we do is try and increase the water level. So pelvic floor muscle training is part of the treatment to help support the structures, but we really have to look at that whole pressure system. Anything that increases the pressure from above, like straining to have a bowel movement, or certain postures and alignments and activities can do that. That's all part of the physiotherapy plan that we do to try and create the right pressure system to be able to decrease that level of bothersome and pelvic pressure that so many patients with prolapse experience. So remember the study, the scoping review showed that urinary symptoms, like that 105 papers, that urinary symptoms was the first domain and first complaint that clients had. Well, the second most frequently reported domain was gynecological. So that includes prolapse, as we've discussed, but other symptoms like dysmenorrhea, like painful periods, or endometriosis. And endometriosis is when they're finding endometrial tissue, which is tissue that should be within the uterus, in extrauterine sites. And clients often present with dysmenorrhea, so painful periods, but they also experience subfertility, and they may also experience abdominal pelvic pain. And in the general population, this is 1 in 10 girls, women, and unmeasured numbers of transgender, non-binary, and gender diverse people experience endometriosis. And in the coming slides, you'll see in this population, this percentage is significantly higher. Again, back to this domain where the second most frequently thing in the gynecological umbrella, pelvic floor dysfunction, was also listed. Now, when we're talking specifically pain as a primary gynecological complaint, clients were often diagnosed with vulvodynia or vestibulodynia. And so this is really under the umbrella of vulvar pain, so pain in the vulva, most often described as burning pain, but it's occurring in the absence of any relevant findings. Vestibulodynia is more right at the opening of the vagina, where people feel a lot of cutting and burning. So in this population, a lot of people also experience generalized pelvic pain, and dyspareunia, which is painful intercourse, was rated at 30 to 61%. And again, just as a comparison, dyspareunia in the general population of sexually active women is at around 7.5%. Now I'm going to talk about another function of the pelvic floor, which is sexual. The pelvic floor muscles bring blood flow to the area, and they are part of being able to reach an orgasm. They provide tone for the vaginal and rectal canals. Remember in the anatomy picture that I showed you, the muscles go around the vaginal opening. So they need to really be able to relax for anything to go in. So if the muscles are tight, which we're going to be talking about, dyspareunia, that pain with intercourse, is very common. Now, research done in 2017 by Morin showed that multimodal physical therapy and a multidisciplinary approach was very effective for decreasing not only pain with intercourse, but improving overall sexual function. So the role of physiotherapy is well documented in the literature. Okay, so this was an online survey that was done in 2021. So the response was almost 1,200 women, and it showed that women with EDS were reported to have an alarming 77% rate of dysprenia. So remember, the previous Gillian et al. Showed 30 to 61%. These numbers might be actually higher than we thought. Endometriosis in this population, it was rated in this survey as over 26%, and remember that's at around 10% in the general population. And there were higher rates of vulvodynia at 50%, where again in the general population that's 8%. All of this to say is that these symptoms are common and that there is something that you can do about it, and conservative treatment is one of those approaches that I hope you consider after today. So the next function of the pelvic floor that I want to talk about is stability, because low back pain is the #1 cause of global stability, and the pelvic floor muscles play a role in unloading the spine. So when we talk about core, the pelvic floor muscles are part of the core. So that's down here. But the core, there is the diaphragm that's part of it at the top. And at the front are the deep abdominals called the transverse abdominals. And in the back we have multifidus, which are the deep back muscles. So front, back, top, bottom. This is really what is the core. And I want to talk about the diaphragm because the diaphragm plays a big role even in pelvic floor function. When you take a deep breath in, your lungs fill with air and your diaphragm comes down and your pelvic floor comes down as well. And when you breathe out, they go up together. So you breathe in, they come down, and when you breathe out, they come down. So you need good diaphragm function for overall core stability and good pelvic floor function. There was a book called Hypermobility, Fibromyalgia, and Chronic Pain that was written by Hakim, who was a rheumatologist from the UK, and Keir, who's a physiotherapist. And this is a quote from their book, that hypermobiles frequently use a bracing pattern with breath holding in an attempt to improve stability and produce more force. So the ribs can become more fixed and efficient respiration is affected. So as I mentioned, the diaphragm is an important role for stability and pelvic floor function. So if people are bracing and holding their breath, it will actually negatively affect their stability and contribute to more pelvic floor dysfunction. So there is research out there that talks about the role of pelvic physiotherapy in working on stability, again, ideally with a multidisciplinary team, but working on various things that looking like at posture, appropriate strengthening exercises, very, very effective. So this was a narrative review that was looking at pelvic girdle pain. Now, when I'm talking pelvic girdle pain, I'm talking about musculoskeletal pain in that pelvic ring. So really present from the front all the way to the back. And there's known causes including trauma or infection, but pregnancy-related pelvic girdle pain has been well established in the literature. So this narrative review was a study investigating pregnancy complications in those with EDS, and they identified that the prevalence of pelvic pain and instability was almost 4 times greater in those with EDS. 4 times greater. So pelvic girdle pain is a common feature experienced by pregnant women, with reports of it affecting between 23 to 65%. And the prevalence of pelvic girdle pain during pregnancy is found to be higher in individuals suffering from HSD. Now, these numbers are even been found to be significantly higher in small case reviews, with numbers going as high as 88%. So treatment, again, in 2008, there were European guidelines for the diagnosis and treatment of pelvic girdle pain that advised that physiotherapy should be first-line treatment. and individualized treatment programs need to be made, and that we need to look at everything like restoring balance and function. We need to look at stretching, if appropriate in this population, strengthening. We want to look at improving proprioception, which is position sense of where you are in space, looking at posture and core stabilization. In some cases, we may even recommend certain belts for support or walking aids. It's really important to consider the impact of pelvic girdle pain on one's mental health. There are several studies that have shown that females with chronic pelvic pain are at a significantly increased risk of experiencing anxiety and depression. And the literature is very conclusive in saying anxiety and depression increase the volume of pain. It's been hypothesized that pain-related fear can lead to a vicious cycle where pain and injuries can persist because of emotional and behavioral responses to pain. Severity of pain also correlates with fear avoidance beliefs. So fear of joint pain and or instability can lead to fear avoidance behavior, and we call that kinesiophobia. And unfortunately, not moving can exacerbate any dysfunction and disability. But symptoms are exacerbated by fatigue and pain. And as I mentioned, depression and anxiety are common, which is why we need to take this biopsychosocial approach when we're treating clients. So this little infograph is from the International Association for the Study of Pain. And I put it here because there's compelling evidence that pain education reduces pain, disability, catastrophization, and can really improve physical performance. So the definition of pain is that it is an unpleasant sensory and emotional experience. And it's associated with or resembling that of actual or potential tissue damage. So the things that I want to point out with that definition is that it could be sensory or emotional. So emotions play a role into the volume of pain, and that it could be really actual tissue damage or the fear of potential tissue damage. Now, the reason I'm telling you this is because pain education is one of the first things we do with anyone that has pain that persists, and your treatments may involve further pain education to give you some self-efficacy and understanding on how you can help with some of those symptoms. So when you come into the office, the first and most important thing is that we listen to your story. We need to know what your symptoms are, what treatments you may have tried. We want to know any surgeries you've had, what medications you may be taking. We ask a lot of questions about bladder function, so how often you go, when and if you experience leakage. We ask a lot of questions about bowels, so how often you go to the bathroom, does it hurt, what does it look like? We also ask a lot of questions about any sexual activity, if you're experiencing any pain from it. And of course, we ask a lot of questions regarding pain, where the pain is, what makes it worse, what makes it better. We administer a lot of validated outcome measures that help monitor change. These can be anything from measuring urinary symptoms, prolapse, or your pain. And because of that biopsychosocial approach, we also administer validated outcome measures that can identify symptoms of depression, anxiety, or stress, catastrophization, all of which we know the research has shown can lead to more pain and chronicity. It can help us also make appropriate referrals. All of this to hopefully give you some hope that there are conservative options and self-efficacy, which are tools that you can use to help yourself as well. So, I have a very limited time to go over our full objective assessment, but I've already talked about all the global contributors. I haven't talked about all of them, but some of them, like we talked about breathing and the connection between the diaphragm is very important. Breathing is probably something most people will get leaving my office, because not only will it help with pelvic floor function, but it is the fastest way into the autonomic nervous system. So that fight or flight can really be changed by facilitating that parasympathetic or that relaxed system just through the way that we breathe. Posture is always very important, particularly in this population. Even not just during the day, but at night, it can make a significant impact on pain. But also, certain postures will change the full function of the pelvic floor. Certain postures will shorten and tighten the pelvic floor. And so we look at posture quite significantly. But for today's talk, my focus is more really on pelvic floor function. So I thought I would go over a little bit of anatomy. And I promise you that there's no test at the end of this. But I wanted you to understand that the pelvic floor muscles actually have 3 different layers, with the first layer being called the Urogenital Triangle. So this layer contains a lot of different muscles and glands, and this can be palpated externally. And as you can see, the muscles go around the vaginal opening. You can't see the back here, but they also, in the deeper layers, this layer go around the anal opening, and they go around the urethra. So this is the first layer called the Urogenital Triangle. So as we go deeper, we get into the deeper layers. So layer 2 is called the urogenital diaphragm. So the urogenital diaphragm contains a lot of fascia, which gives a lot of stability and is the insertion point of the various muscles. And fascia is important in this layer because it's continuous with that anterior abdominal wall. And that's why we also look at the abdominal area for any scars. So any scars in the abdominal area could affect some of the pelvic floor function. And then as we go deeper, we get to layer 3, which is called the pelvic diaphragm. So this is the deepest layer. So you may have heard of the levator ani. It's probably the most popular pelvic floor muscle group. The levator ani is actually 3 different muscles as they're listed here. And coccygeus is also in this deeper layer. So that's a deeper muscle. It's called ischio-coccygeus right here. And I wanted to point out that there's also 2 hip rotators in this deep layer of the pelvic floor called the piriformis here in yellow and obturator internus. Now, piriformis can be palpated externally, but obturator internus can only be palpated through internal techniques. Now, the pelvic floor muscles are very important muscles, as I've mentioned, and they have different types of muscle fibers. They have muscle fibers that are fast twitch and slow twitch. Now, we give exercises appropriately to really address the slow twitch and fast twitch muscle fibers because we need these muscles to come on quick when we need them, and we also need them to have good endurance. And I guess just a fun fact that these muscles are innervated by the pudendal nerve that come from S2-3-4. And this is a very cool nerve because it's the only peripheral nerve that has sensory motor fibers and autonomic fibers. And it's those sensory fibers that can unfortunately contribute to pelvic pain. Okay, so some of you may have heard of Kegels. Kegels came about, I guess, in the 40s when Dr. Arnold Kegel, who was a gynecologist, named these exercises after himself. And it really was for his postpartum population that he felt needed to strengthen the pelvic floor. And what he did was he used single finger palpation to touch the muscles to give feedback to clients as to whether they're contracting these muscles correctly. He also used the perionometer, which is a squeeze pressure device, again, to let patients know if they're squeezing correctly or not. Unfortunately, throughout the years, this has deteriorated to a lot of just verbal or written instructions, and people are doing things like stopping the flow of urine on the toilet, which is very bad. Please don't do that. And when I assess people through internal techniques, and the research shows this as well, more than 30% of women are not contracting their pelvic floor properly. Sometimes they're actually doing the opposite, they're bearing down. Now, there's two types of things that we could feel when we do our internal techniques. Any muscle could have increased tone or decreased tone. So disorders of decreased pelvic floor tone are often muscles that are thinner and weaker, And typically clients are experiencing leakage or pelvic organ prolapse. So pelvic floor muscle training is indicated in this group. Now, disorders of increased pelvic floor tone, so that's when a muscle feels tender or tight or feels like little knots in it. So in this group, clients are often experiencing pelvic pain. They may have urinary urgency or frequency or urge incontinence. They may be having pain with intercourse or have constipation. We never give pelvic floor strengthening to a group of a muscle group that has increased tone. We want to normalize that tone before we start strengthening, and that's why I wanted to debunk the myth that pelvic floor strengthening is for everybody. And the advantage of having an assessment by a pelvic health physiotherapist, they'll be able to tell you if the muscles do need strengthening or if they need lengthening. So this was a study on joint hypermobility amongst female patients presenting with chronic myofascial pelvic pain, and they showed that muscles of the pelvic floor most commonly associated with pelvic pain were some of the ones that I showed you on previous slides, including the two hip rotators. So being able to palpate these muscles will let us know if they are contributing to the symptoms that patients are experiencing. So if we're able to touch it and people say, oh, that's the pain I get, what we call the comparable sign, then we know by decreasing that sensitivity or tension, we can help alleviate those symptoms. And the research shows that many patients would benefit from individualized physical therapy treatment plan to focus on neuromuscular re-education and joint stability. And that re-education, as I mentioned, may involve more down training or relaxing of these muscles. And in this population, the presence of generalized hypermobility disorder, it was associated with a higher likelihood of, so the pelvic pain was, you also could be experiencing that pain with intercourse, low back pain, hip pain, stress urinary incontinence, or irritable bowel syndrome. So gastrointestinal symptoms are also very prevalent in this population, with the most common GI symptoms being nausea, abdominal pain, constipation, and diarrhea. And unfortunately, these symptoms have been shown to get worse as you age. Now, defecatory problems are greater in the EDS group, with significantly more patients reporting straining to have a bowel movement, feeling that they haven't completely emptied, or needing to perform digitation to defecate. In order to empty, they need to use their finger. Now, constipation may be secondary to physical obstruction from pelvic organ prolapse, but it's often multifactorial, and it's really important to have a thorough assessment done by your primary care physicians. But for the constipation, there's a lot from a physiotherapy perspective that we can do to help improve it. And it's so important to address constipation because straining has a lot of negative things, including can contribute to more pelvic organ prolapse. And when you strain, you're actually causing little microfiber tears within the muscle that heal, but they can heal in a shortened and tightened position, which could contribute to pain and difficulty emptying. So a big part of what physiotherapists do is education. So we talk a lot about normal bowel function. And so normal bowel function could be that you have 3 bowel movements a day or once every 3 days. But what's important for us is what it looks like. So on this Bristol stool chart, we want it to look like type 4, so soft and smooth. You should not be straining. You should not be having pain when you're having a bowel movement. So there's recommendations that we can make to help improve your bowel function by even just bringing attention of never ignoring the urge to have a bowel movement. You know, when you get up and you eat and drink in the morning, there's a reflexive mass movement that happens that you should feel the urge to have a bowel movement. And if you ignore it, that urge is going to go away and the stool sits there and loses hydration, which contributes to more constipation. You know, using a step stool in the bathroom so that your knees are above your hips will help you evacuate easier. We may teach you things like an ILU massage that can help facilitate going to the bathroom. Hydration is really important. So many clients, especially those with leakage, stop drinking fluid water because they think that it contributes, but it actually has the opposite effect. We don't know what the right number of glasses of water to drink is, or I don't. It depends on your weight, your activity, the weather. But what we want is that you drink enough so that your urine is a pale yellow color. It should not be dark. Drinking more will also help improve your bowel function. So it's not uncommon for us to administer a bladder diary so we can see when you're going to the bathroom throughout the day and what you're drinking so that we can make recommendations. So the diet modifications are really just identifying things like bladder irritants, things that will make you urinate more frequently, like alcohol or caffeine, spicy food or citrus fruits and juices, even artificial sweeteners. A lot of our education involves behavioral modification to help improve your symptoms, and that recommendation is really based on your presentation. I already talked about pain education as part of our education. Vulvar care is also really important too. What many people don't know is that you shouldn't be washing your vulva with soap. It should only be water. And vaginal dryness is reported in 25% of this population. So anything that we can do to decrease the irritation in the area is really quite important. And sometimes there are recommendations around what type of pads to use. I don't have time to go into sleep, but sleep is something that is so essential for our health, and there are recommendations that we could make to help improve your sleep quality. So I wanted to end with this one international survey study which looked at pelvic floor symptoms in cisgender women with EDS. So this was an online questionnaire to really help understand obstetric and gynecological experiences, and there were over 1,300 respondents. So this was a large observational study, and it demonstrated that clients with EDS reported a higher prevalence of pelvic floor symptoms that are more severe than the general population. So I'm not going to read through each one. There were previous studies that indicated it too, but it's really great to see that there is being more research and attention given to really these symptoms that have huge impact on quality of life. So what symptoms or conditions can a pelvic health physiotherapist treat? I've kind of lumped them into 4 different categories. There could be urological, so incontinence or urinary frequency or urgency, getting up at night to go to the bathroom or not being able to empty your bladder. They could be gynecological, so we talked about the pelvic pressure that people might feel with pelvic organ prolapse. We can see people pre and postpartum, various pelvic pain conditions. We also treat different types of bowel dysfunction such as constipation, irritable bowel syndrome, even fecal incontinence. And pain is definitely one of the most common things that I treat. So that could be pelvic pain, pelvic girdle pain, painful periods, pain with intercourse, and all the different conditions that I talked about earlier as well. The only thing that I didn't talk about that's in this slide is coccydynia, which is really just tailbone pain. And we do treat a lot of tailbone pain because in the anatomy you saw that these pelvic floor muscles insert into the coccyx. So pelvic pain, tailbone pain is another condition that we do treat. So what can you expect from a pelvic floor physiotherapist? So it's a one-on-one assessment and treatment with someone that has appropriate postgraduate training in pelvic health, and we take that biopsychosocial approach. We do a lot of education. Our treatment may involve breathing exercises. We do things to improve both your bowel and bladder routine and symptoms. We really want to improve your kinesthetic awareness. Just where are your pelvic floor muscles? When are they contracting? When are they relaxing? And then once we have assessed to see what the state of your pelvic floor muscle is, then we can make an individualized treatment program, which may involve pelvic floor muscle training. If there's increased tone, so that tension, then we may use various manual therapy techniques as well to help decrease that. We can help improve sexual function. And as I mentioned, self-efficacy is a big part of our approach because there's a lot of things that we can provide to you for you to do for yourself to help alleviate your symptoms. And collaboration, as I mentioned earlier, is really quite important as well. So how to find a pelvic health physiotherapist? If I've intrigued you a little bit, then a couple of options that I've listed here are my teaching company's website, which is pelvichealthsolutions.ca, and you can find physiotherapists that have had this training and by region, and you can see what courses they've taken and how long they've been practicing. And another great website is from the Canadian Physiotherapy Association, so physiotherapy.ca, and you can help find a pelvic health physiotherapist. I wanted to thank you so much for your attention. It really is an honor and privilege to have had the opportunity to talk to you today. Thank you.